Hi, I'm Ross, and today I'll be talking with you about bipolar disorder. Now, I know there are a lot of misconceptions and social stigmas about this disorder, so hopefully today I'll clear some of those up for you. Bipolar disorder involves an intense and very disruptive experience of extreme elation or euphoria, possibly alternating with major depressive episodes. There are two types of this disorder, bipolar 1 and bipolar 2. In bipolar 1 disorder, the individual experiences one or more manic episodes with the possibility, but not necessarily, one or more major depressive episodes. You're probably aware of what a major depressive episode consists of. The diagnostic features include either a depressed mood or diminished interest or pleasure in all or most daily activities, significant unintentional weight loss or appetite decrease or increase, insomnia or hypersomnia, psychomotor retardation, which is slowing down of bodily movement, or psychomotor agitation, which is when the behavior of the individual has a frantic quality. Also, fatigue or energy loss, feelings of worthlessness or inappropriate guilt, concentration difficulty or indecisiveness, recurrent thoughts of death or suicide. If untreated, most depressive episodes usually run their course after about 6 months. Now on to the manic episode. During this manic episode, a person may seem outgoing, alert, talkative, creative, witty, and self-confident. These last at least 1 week, in which 3 or more of the following symptoms persist: inflated self-esteem or grandiosity, decreased need for sleep, increased talkativeness, flight of ideas or racing thoughts, distractibility, increase in goal-directed activity or psychomotor agitation, excessive involvement in pleasurable activities with potentially painful consequences. Strangers may view these people going through manic episodes as extraordinarily outgoing, friendly, and imaginative, though those who know the individual recognize that something serious is happening. The euphoria of a manic episode may suddenly turn into extreme irritability, even aggressiveness and hostility, especially if other people confront the person about this manic episode. Suicide is a very high risk during both manic episodes and major depressive episodes. A manic episode typically appears and ends suddenly. They usually last from a week to a few months. Following one manic episode, there is a 90% probability that the individual will experience more episodes. Manic and depressive episodes are usually separated by a normal mood. Extreme manic episodes can sometimes lead to psychotic symptoms such as delusions and hallucinations. A diagnosis of bipolar 2 disorder means the individual has had 1 or more major depressive episodes and at least 1 hypomanic episode. Those with bipolar 2 disorder have never experienced a full-blown manic episode, but have become sufficiently energized to meet the criteria for a hypomanic episode. In a hypomanic episode, there are no psychotic features, and the episode is not severe enough to cause marked impairment or to resuscitate hospitalization. It's just a mild form of a manic episode. Most subsequent manic episodes occur just prior to or soon after a major depressive episode. People who do not receive medication for the treatment of their bipolar disorder average about 4 episodes within the span of a decade, with the interval between these episodes decreasing as the individual grows older. An individual can also experience a mixed episode, characterized by a period lasting a week in which the symptoms of both a manic episode and a major depressive episode occur together in rapidly alternating fashion. A mild form of bipolar disorder, cyclothymia, involves periods of hypomania and mild depression with less severe mood swings. People with bipolar 2 disorder or cyclothymia may be misdiagnosed as having depression alone. Now, bipolar disorder has a lifetime prevalence of 3.9%. Bipolar disorder is almost equally prevalent in males and females, although there's a different form in which the first episode occurs. The first episode for men is more likely to be manic, and for women is more likely to be depressive. This most commonly appears in people in their 20s. In adults over age 65, the prevalence rate is estimated to be 0.1%, although misdiagnosis may occur due to the coexistence of medical illnesses. At present, the most widely held biological theories focus on altered neurotransmitter functioning as the cause of mood disorders. The earliest theory was the catecholamine hypothesis, which asserted that a relative shortage of norepinephrine causes depression and an overabundance of norepinephrine causes mania. Another theory is the indolamine hypothesis, which states that a deficiency of serotonin contributes to the behavioral symptoms of depression. Researchers hypothesize that abnormalities in the structure and function of certain brain circuits could underlie bipolar and other mood disorders. Some studies have found anatomical differences in areas such as the amygdala, prefrontal cortex, and hippocampus. However, despite 25 years of research involving more than 7,000 MRI scans, studies continue to report conflicting findings, and there remains considerable debate over the neuroscientific findings. For mental, emotional, and environmental issues, stressful life events are thought to be the main element in the development of bipolar disorder. These can range from a death in the family to the loss of a job, from the birth of a child to a move. It can be pretty much anything, but it cannot be precisely defined. With that in mind, research has found that stressful life events can lead to the onset of symptoms in bipolar disorder. However, once the disorder is triggered and progresses, and the cycle begins, psychological and/or biological processes take over and keep the illness active. Treatments for people with bipolar disorder are usually somatic treatments. Antidepressant medication is the most common form of somatic treatment for people who are depressed, and lithium carbonate is the most widely used medication for people who have bipolar disorder. The most common medications used to treat depression are tricyclic antidepressants, monoamine oxidase inhibitors, and selective serotonin reuptake inhibitors. Another form of treatment is electroconvulsive therapy, or ECT. ECT is usually administered 6 to 8 times once every other day until the person's mood returns to normal. Electrical current is used to cause a brief seizure of the central nervous system while the patient is under anesthesia. Some individuals benefit from maintenance ECT, in which the treatment is administered over a period of several months to prevent a recurrence of depressive symptoms. Interpersonal and social rhythm therapy, IPSRT, is a biopsychosocial approach to treating people with bipolar disorder that proposes relapses can result from the experience of stressful life events, disturbances in circadian rhythms, and problems in personal relationships. Clinicians work with the client by paying close attention to the regularity of daily routines and the extent to which life events, positive as well as negative, influence daily routines. The goal of IPSRT is to increase stability in a client's social rhythms. Most people with bipolar disorder act and feel normal between episodes, although approximately 1/4 continue to show unstable mood and to have problems in their dealings with other people, both at home and at work. Bipolar disorder is a very serious condition if untreated. The risk of suicide among people with bipolar disorder who do not receive treatment is estimated at 15%. If you think you or someone you know has bipolar disorder, please contact someone and look for help.